University of Maryland School of Dentistry in 1970. He's been in practice doing integrated dentistry for over 31 years, and 5 years of nutritional therapies. Dr. Baldwin has a DS in psychology, Master in Science of Holistic Nutrition. He's certified in personal metabolic nutritional typing department. He received a mastership in the Academy of General Medicine in 1972 and is a fellow and a past board member of the IAOMT. It's my pleasure to introduce Dr. Thomas Baldwin.
Thank you very much. Thank you. I'm going to read this disclaimer. We all have to do that. I do not have any financial interest of a product in my talk or with any companies offering grant monies for this continuing dental education and medical education program. The fellow's going to help me out today. Bill Landers is with Ortec Company, so he does have a financial interest, and I always used all of Bill's products, and I'm going to be talking about them in this slide, and Bill helped me with doing the slides. So that's a little difference there in the two of us. I want to first of all go through some slides. Now, many of you have heard me lecture before, and I talked all about, one of the things I skipped was I started off on periodontal disease, what it does medically. All the different medical syndromes associated with periodontal disease. It's unarguable. The literature is that thick, showing that periodontal disease does cause various systemic ailments. For instance, a couple of years ago, surgeons took samples of plaque in the arteries that were building up to close the arteries. They put them on a culture medium. They found Porphyromonas gingivalis. Gingiva, comes from the mouth. So we know how serious periodontal disease is. I'm not going to go into that anymore today. But after I would talk about that at some length, I'd start talking about diagnosis, and I always said the thing that I still say, and that is that if you do not have a microscope and use it, you should not do biocompatible periodontal therapy. Period. End of sentence. That's it. If you don't have a microscope, don't do it. The reason I'm emphasizing that so much in preaching to the choir here is I still will get calls all the time, emails, and people ask me about patients that they're talking about periodontal problems, what to do about them, how do they know if they're getting better. You can tell all these things clinically. I've retired from dentistry. I have a nutritional counseling practice now where I deal with, obviously, toxicity. And this periodontal disease, as you'll see here today, is a horribly toxic condition. You heard someone this morning talk about bacteria breaking down and releasing toxins into the bloodstream. I think it was Vera Stetkel. And so we know that it's very toxic, and that's what I do now. But I still get calls a lot about doing this, and I'll say to people, what does the slide look like? Well, I don't have a microscope. Well, then you shouldn't be doing it. It's so much easier to say this to a group like this than it is to say it, for instance, to someone individually right up front. Thank you, Ron. That I want to emphasize that. You must have a microscope. My personal preference for that is a microscope with the oculars where you can look through and not just use your monitor. It's a little more money. Trust me, if you do biocompatible periodontal therapy, if you look for the bugs in people's mouths, this microscope and the monitor and everything else will pay for itself easily in 3 months. Easily. It should pay for itself in a month. That's a lot of money. And after that, every bit, and that's just diagnostic, that's not treatment. Every bit of money that comes in should go to pure profit line. I even know hygienists that we've taught, Bill and I. Bill was my original mentor in all this. Bill and Dr. Paul Kais mentored me years ago and got me into this field. But I've even known hygienists who have offered to buy the microscope for the dental office if they get all of the proceeds. The cost of the slide, the cost of the irrigation, the cost of any biocompatible periodontal therapy. Why not? Well, of course, dentists always hear that number, and they say, well, maybe I ought to look at this. But then after that, I would go right into treatment. How do you treat periodontal disease? How do you get rid of the bugs and that sort of thing? The problem with that was I was skipping by the diagnosis. That was my feeling. I started talking to Rich Chan, and he said, how about doing a breakout? Then I understand after yesterday's beginning sessions, there was a lot of talk about perio, and we're talking about doing several, at least 2, maybe 3 breakouts at the next meeting. So we'll get into really the nitty-gritty of doing it, not just the theoretical concepts of causing heart disease, brain problems, joint problems, etc., 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 all contributed to by periodontal disease, which is why I use the microscope in my nutrition practice. It's really great to have the monitor get a little sample out of the sulcus. Especially beautiful is when they say, well, I just had my teeth cleaned. And so we take the sample and we show them a monitor that's really swimming with bugs. And I can say, you know, if your slide looks like this is your mouth, you can't be healthy. If you're healthy, your mouth couldn't look like this. It all ties together. So it gives me a chance to do something, and it gives the dentist, when they go talk to him, a chance to call up and say, well, what are you talking about? So far from dentists, I've had zippo calls. Now, I'm in a rural area. Maybe they just don't believe in periodontal disease. But be that as it may, cover slide here, we're going to go through some of the real nitty-gritty techniques of the slide, getting the slide and the interpretation. We're going to make it fairly simple, and so let's just skip through this. I've been a fellow in the Academy and also accredited for quite a few years. Interpretation of the microscopic slide in periodontal diagnosis. So this is what I'm going to be talking about today. I'm limited in time, so I'm going to try to rock and roll. Phase contrast video microscopy, that's what we're talking about for our main item of diagnosis. I've had people come up after I've talked to this group and many other groups and say, well, you don't recommend doing probings. I've never, ever said that. I did probings on every single patient. I don't do it now because it's not germane to what I do. But I do probings. I do put down tissue tone. I do take a complete medical history, on and on and on. I do all those things. I do the classic along with the microscopic diagnosis. But today we're talking about microscope. Advantages. You can do it at chair side. It's fast. It only takes 2 minutes to do a slide. And that's if you're taking your time and talking. It's cheap, about 25 cents a test for all the materials we'll talk about. And it identifies various things, the morphotypes, the spirochetes, white blood cells, protozoans, and so on. So you can actually identify them. It gives you an antibiotic verification, and it gives you your treatment verification. For one thing, is what you're doing working, efficacy, and whether the patient's complying at home. You can tell that. Now, I don't ever say, well, the patient's not complying. That's because the patient's a bad person, doesn't do it. Sometimes it just means we have to go back and re-emphasize things. Re-emphasize the use, primarily, in my opinion, of oral irrigation. Patient motivation is the big reason for using a monitor. It's the big reason for using a microscope actually over diagnosis. Because if we can't motivate the patient, as you've heard me say before, again, those of you who have heard me, easy for me to say, if you can't motivate the patient, nothing's going to work. If the patient won't do things at home, the doctor can't accomplish anything. I don't care what aspect of medical science that is. So these are the things, real big advantages. Our movie's not working, so I can't play the movie. But health and disease, basically, I'm going to go over this more, and we'll look at a slide together here in a few minutes. But basically, health might be real crowded and look crowded, but it's not moving. It's still. If you go a little ways away from this, you'll find an open area that has nothing moving. Now, this is disease. And again, it looks like this should be healthier than this, but when we look at our slide with the microscope, you'll see movement. And that's the key term. I don't care if you're looking at Porphyromonas gingivalis, Peptostreptococcus micros. We can't really tell those from the microscope. We need for those particular bugs to do a culture. That means going down in the pocket and pulling it out and sending that off. Again, that's not what this is about. But the movement, I can't say that enough. Okay, now, that's for risk assessment, patient motivation, obviously. Disadvantages of doing this technique. The initial cost is from $3,000 to $7,000. That's, I know, less than monitors in your office to watch the Weather Channel. It's less than some video cameras. It's a lot less than a lot of things I see in dentist offices. The same dentists will say, well, I can't afford a microscope. Again, this will pay for itself in, at the most, 3 months. Those of you doing it know that. Disadvantage is it doesn't give you an antibiotic specificity. Now, really for that, it's just telling whether the all the microscope can do is tell you if an antibiotic that you happen to be using is working. I'm more interested in whether my technique is working, whether their home care is working, not as much in anything about antibiotics. I can tell you before, I had like 5 or 6 years, wait a minute, maybe I'm underestimating, about 8 years, that I did really what you might call routine dentistry before I became what classically was called a holistic dentist. That was a lot of years ago. It was about 30 years ago. And when I was doing that, I wrote out, talking about antibiotics, I went back. When I retired, I had sold my practice. I had all my prescription pads I'd ever written. And so I had too much storage room. And so I went back and looked at those. In my early days, I was writing about a prescription pad about every 2 to 3 months. At the end of my career, the last prescription pad was 3/4 used and was 4 years old. Now, either I was doing something wrong before or doing something wrong after, or something changed. But I think what happened was I was writing out too many scripts, typical of most doctors today. Oh, let me back up here. Okay, unfamiliar technology. Now, let's talk about that real quickly. The compound microscope for detection of pathogenic microbes was in 1495. There's no way around that. That turns out to be, what, 513 years ago. It's time to catch on. This is not unfamiliar technology to any of us. We all had, hygienists and dentists all had, what was it? Well, you had zoology, you had histology, and you looked in a microscope. Now, patients might not be as familiar, but they probably are. They know that when they have a child go in the emergency room, they take a slide, they look in a microscope, they probably do a culture. Okay, glassware. We're going to talk a little bit about glassware. Again, this is the nitty-gritty of doing these microscopic tests. Well, never reuse your glassware, invisible residues, and again, don't cheap out on it. We don't cheap out on things like that. You got to get rid of your glassware after you use it. Handle by the edges, just so you don't get fingerprints and oil all over it. Avoid fingerprints and oils and glove powder. That's what I thought was coming up next. The cover glass is 1.2 to 1.5 thick with optical measurement. It doesn't really bother you, but that's what you're going to be using on your glassware. Now, I use something that Oratech again sells. It's called OraPrep. It simulates crevicular fluid. It's made to be that way. Why? We don't want the bugs dying right away. You know, one of the things we're looking at is anaerobic bugs. So we want to get them out of the mouth, out of the bottom of the pocket, which you'll see in a few minutes, and we want to get them on the slide as quickly as possible. Now, the reason we want to do that is to keep them alive. Many of you might know, and this just shocked me about a year or two ago, I work a lot with Metametrics Labs, which has also got a booth in there. In fact, the ND that is at that booth today, it's really funny because I've talked to her, I'm sure, 100 times on the phone, just met her today. So that was sort of nice. But we want to keep them alive. But what I was going to say real quickly was, until recently, some of you are familiar, hospitals, if you went in with GI problems, they do a fecal test and you look for bugs. What they're looking for is anaerobes. 95% of those get dead before they've got the sample ready to ship. So all these years we've been doing fecal test specimens for bacteria, protozoans, and so on, and they weren't working. We were losing 95% of the bugs. Metametrics now does what's called a GI effects test, which looks for DNA of these dead bugs so they can identify them. So all those years, all the gastroenterologists doing all those fecal tests, they have meant almost nothing. Okay, simulates crevicular fluid so we can keep them alive longer. It's pH balanced, keep them alive, preserves the cell appearance, preserves normal activity. All the things I just mentioned, extends your sample life somewhat, so sometimes later in the afternoon you can look back at a slide you got in the morning and it's still going. The procedure, place a drop of the OraPrep first. Pool the plaque samples in the OraPrep drop. Now we're going to look at another slide of this, but let me emphasize, hygienists in here and dentists in here that do a lot of scaling, curetting, whatever, when you get those really thin instruments that you say, oh my God, this will break off on calculus, throw it away, that's what you go after your plaque samples with. real thin, real narrow. You can slide down there to get to the base of a pocket. We want the bottom third of the pocket. So that's what you want. And you're going to pool all your plaque samples together. And basically we're going to talk about taking several different plaque samples. That's not always necessary once you get good at it. And don't mix them up or disrupt them. You're going to be putting them together anyway. But here's what you want to do. The fine curette or scaler, you want to get down to the apical third of that pocket. That's why a big, thick scaler, as you know, will usually stop here. Okay? So a little thin scaler gets down and gets that plaque. You generally are not going to find a lot of calculus down here, and it doesn't matter whether it's there or not, frankly. Tests have shown it really doesn't. But you want to get out this plaque. But first you want to use it for diagnosis. That's what we're talking about today. Get it from the apical third, which is the most anaerobic, without oxygen portion. These bugs die in the air. And get 3 deep pockets or so. If you feel you got to the base of a deep pocket, you can use 1 sample. But when you're learning this, try to take several. And just take a look at them. You can do 3 different slides. God, you've run your cost up to 75 cents for this $25 charge. Not bad. Avoid calculus. The reason for that is when you put the cover slip on and push it down, it can break the cover slip, or you'll never get it sealed enough to see anything. So avoid the calculus. You're not scaling here. You're just getting the soft, free-floating, unattached plaque. The stuff floating around down in this pocket. You just want to get down and get right in the middle of that pocket. Okay? Now, you want to transfer the plaque sample, and the way we do that is just transfer off that curette where you've picked it up, just gently push it into the OraPrep. And if you do that coming right out of the mouth, most of those bugs are going to stay alive. Don't disrupt the sample. Leave it in a clump. You don't want to break it up yet. You don't want to smash it yet. And you pool your multiple samples in the same drop. You don't have to separate them. I just want to know if the busiest part of that slide, the busiest part of that slide is your problem in the whole mouth. You want to avoid false negatives. What you want to do, any positive is positive, and that's it. So you're going to look individually, track specific slides. What you do with that, you can get multiple slides. But you really don't have to. Just want to know if it's busy. Cover glass, handle by the edges again. Keep off the oil, keep off the fingerprints. You can flick the edge off to separate. Sometimes they'll be sticking together. Again, after a while, I notice they're so cheap, you can throw 2 away. It doesn't matter, but you can separate them easily. Just flicking them, they'll come apart. That's if 2 little cover slips stick together. Put it at a 45-degree angle, okay, and let it drop down onto the drop of OraPrep. So just let it fall down. Now, you want to compress the sample, and you invert it with the cover glass down on a paper towel, and you compress it. And what you do with that, firmly enough to blanch a fingernail. I didn't use an instrument. I used an instrument a couple times, and it broke the cover slip. Wasn't good. So I would use my finger, my thumb, to press it down. Press it nice and hard, upside down. Get out all those air bubbles. Get that feel so it's just the plaque in the OraPrep. That's what you want to do. Again, this is just nitty-gritty. Okay, a depth of field, you got a slide. You got your cover glass. You got the microscope sitting up here, remember. The optic is coming down on that. And you've got your sample. So what happens is you have a limited focal plane. All right? Now, using just the fine, you got only the thin slice of this plaque sample in sharp focus. But using the fine focus, you can move it up and down to look through the entire sample. Just the fine focus. And you're going to be bringing those bugs in and out of focus. And that's going to give you your picture that you want to see. Now, Oraseal is another substance that Oratech sells. And different companies have these. It's just that when I'm doing this, I'm not compromising whatsoever on quality. Some of you might remember Avram King from years ago, but he used to talk about the discriminating patient, discriminating client, a non-compulsive desire for excellence in all phases of their life. Well, that's how I felt about doing this. I wanted to be the best at doing it. I didn't scrimp on any materials. I didn't look for a cheaper one. Oraseal's a good one. Gives you a better risk assessment for several reasons, for fewer false negatives. 1 in 3 slides will be significantly riskier. What we mean by that is actually it takes 20 minutes to actually show something up. Preserves natural activity and keeps things alive for hours and eliminates evaporative streaming. Evaporative streaming occurs when you look in your microscope and it looks like there's a river, a fast river flowing, filled with all kinds of debris, maybe bacteria, maybe not. When you see that fast river moving, the slide's not sealed properly, evaporative streaming. So that everything will be moving around. What I used to do with that is either get a new slide or I would go back in and reseal around the edges. That didn't always work real well. There's our gal from Metametrics. I was just talking about you. All nice things. Don't believe what they say. Apply the Oraseal, the next thing that goes on there. Put the Oraseal right around the edges of that cover slip. You've got it thinned out. You've got your sample thinned out. And you apply just a thin film right around the edges. Overlap. Overlap. All four edges. I don't want those corners having that evaporative streaming. And about 20 minutes after you seal is the best thing to do because some of these bugs will come out. Bill claims that spirochetes are photophobic, and when they see light, they run away. But they will come out after a period of time. The protozoans come out after a period of time. So give it about 20 minutes. Once you get really good at doing it, you're going to take a look almost immediately, but you don't have to do that right away. I would make sure this Oraseal is set and dry before you put it on your microscope. Because if you run the optic through the Oraseal, well, I've never had success cleaning it off. There's a substance that Bill has that will clean it off, but I never had good success at that. So I would scream and yell at the hygienist, and she'd say, Tom, you did that. And I'd say, oh, that's right. Well, it wasn't so bad. So about 20 minutes after sealing. But let it set, and I would put it on the light because the warmth of the light will get those things going again. It's a shock to bugs to be taken out of the mouth and transferred. So the warmth of the light will get them going again. Okay, risk factors. These are the things we're going to be looking for. I'm going to go through these sort of quickly because we're going to talk about them individually. Okay, spirochetes, treponema. We all remember from dental school, or at least I did at Maryland, we were downtown Baltimore, so there was a big thing about treponema pallidum, cause of syphilis. That was rampant in Baltimore at one time. I don't know about now. But these are the spirochetes, just squiggly things. So you'll see in a slide. We have good spirochetes on our slide. 57 known oral species. They have flagella, internal spiral axis styles. Not the flagella like you see on a trichomonad we'll see in a few minutes. Cytopathogenic. They're pathogens. Degrade proteins. And that's how they do it. Again, of the 57 species. We see all different kinds. What you're generally going to see is basically A and B, sometimes F. I haven't seen a lot of this, but they will get in when you have big buildup of them. 1 micron. That's all you can see. And that's different examples of ones from different slides. And this is showing the large spirochete. You can see that's a rod called a cigar rod and a small spirochete. Cigar rods, look at the shape of them. They're small, and they move pretty quickly around a field. To me, that's a stage of advancing periodontal infection. So those rods, cigar rods, I called them. Organization, you'll look for that. You can see almost slippers. I've heard them called slippers, and they start to organize. You'll see a lot of organization of spirochetes around white blood cells, ripping the white blood cells to shreds. That's a bad dude. And this is showing about the actual size you'll see on your microscope. That's the actual size. It's small. It's very tiny, and the microscope blows it up a lot, of course. But that's what you're going to be looking for. This is corn cobs. They form. They start forming in here. We'll see more of that on the Fusobacterium nucleatum. The spirochetes start forming around there, the corn cobs, and so on. Porphyromonas gingivalis. I'm not going to use this for a diagnosis of Porphyromonas gingivalis. I want to see a culture to do that. And we can talk about culture if we do. I think we're talking about breakouts. The next one in San Antonio, and if Bill and I do a couple of those, we'll get more onto all that sort of thing. This is just aimed to be the microscope. Just a different idea with some names of what they're looking at here. And they go through basically almost the whole thing again. And okay, we're going to talk about the spirochetes. Again, you're going to see this a lot better in this field, see how they're little wormy type things, squiggly. Okay, yeast you'll see. And this is a typical sort of yeast cell. You look for this hypha on the top. You look for this clear part of the body. It'll be a long, looks like a rod, but it's got a clear body. And quite often a little enlargement at the head. Okay? Those are called the mother cells. Daughter cells, buds are often missed. And slightly ovoid cells, half the size of a red blood cell. Red blood cell was in there. I want to get on to our slide as quickly as possible. As you can tell, 45 minutes is tough to do this in. Trichomonas oralis. I got to tell you, I didn't see a lot of this, but I did a course in East Texas. Went to someone's office. Kathy and I went to their office and spent a day with them. We had a morning lecture and for the whole staff, hygienists and everybody, front desk, everybody. And then we had 3 patients that they were having trouble with. And so we worked with those 3 patients with the whole staff. And it was really, really a fun, great day for them, really educational. But in East Texas, they have a lot of these trichomonads. We didn't have a lot in Maryland, so I don't know the difference there. I think they're attracted to good football areas. That's not Maryland. Okay. Protozoan, they're protozoans. They are not bacteria, the same as the amoebas we're going to get to. Trichomonas oralis, almost indistinguishable from Trichomonas vaginalis. Disagreement among microbiologists as to whether a separate species. Who cares, right? Probably not causal, but highly associated with advanced disease. Many people think the protozoans are not causative of periodontal disease, but they are facultative anaerobes that go in there because you have the disease, the infection, and they come in because they love to eat that stuff. So that's where you'll find them. That's just an example of one of the trichomonads. They'll have a little flagella coming out of the end. They wave that and they move around. They swim around. Amoebae, we saw a lot of these. Again, in more advancing cases of periodontal infection. And this is what you're going to see right in there. That's the amoebae. They have all these multinucleated, not a white blood cell, even when it's perfectly round, because there's no cytoplasmic granules, which will come, okay. Multiple vacuoles throughout, like this. That's an amoeba. Affinity for dead white blood cells, like those things, they come in and sort of clean up. Probably not causal, but highly associated with advanced disease. I showed a gastroenterologist in my practice. He was in, he had a very clean mouth. We were talking, he says, well, do you ever see like amoeba or anything in the mouth? And I said, yeah, and I had a slide from the patient before and I showed it to him. And when he looked at all the amoeba running around this slide, he said, if we see these things in medicine, we put them on extremely strong antibiotics, and if there's enough of them, we hospitalize them. Dentists don't even look for them, most of the dentists in the world. And that's right there. My opinion is, I think it's causal. But again, it's a matter of opinion. You want to get rid of them. Whatever that means. And these are multiple amoebae. And again, you can see TNC spirochetes in the background, and they're organizing, they're getting organized. Unfortunately, this doesn't translate well. The slides don't translate well to video, I'm sorry. But again, the oral bacteria. How fast do oral bacteria grow? Population doubles every 4.8 hours. Okay? According to Walter Loesch, University of Michigan. This is a white blood cell, primary inflammatory cell. Now, let me go through this a little bit. Highly diagnostic, correlate better than probing, bleeding, or radiographs with periodontal infection. Sparse and healthy sulci. Okay? Numerous in inflammation, and there's 4 main types. But let me tell you something. When you first come in, an advanced perio patient, my experience has told me they may not have a lot of white blood cells. They may have primarily, they may have a lot of spirochetes, they might have amoeba, they might have trichomonads, red blood cells from bleeding. We don't want to see those, but they come there with bleeding. But you may not see a lot of white blood cells. That doesn't mean a lot. What it means in some cases, in my opinion only, is that the body has started to give up this battle. It's just being overwhelmed. You pull back your forces, you regroup, and you get out of there. You're losing the battle. Our job is to win that battle. So we will often find a slide of someone with advanced periodontal disease. How do I know? Their gums are red. They're bleeding like crazy. They've got deep probing desks. The teeth might be mobile, etc., etc., etc. You've heard it a billion times. But on the slide, we may see a lot of the spirochetes, the things I mentioned, but not the white blood cells. So we go in there and we start cleaning things up. We do our therapy. Another lecture. You've already heard it, those who have been in the academy for a while. And hopefully in San Antonio or maybe Las Vegas we can go through the whole thing again. But, and let me tell you folks, this is an income generator where you go home at night being well reimbursed, so are the hygienists, the whole office staff obviously is, and you've done a good thing. Okay? Nobody's going to be calling you back saying, you know that beautiful crown you did on the tooth that didn't hurt, Doc? Well, it really hurts. You don't have that with this. So it's going to be real rewarding to do it. But anyway, back to what I was saying. You're cleaning them up, and the next appointment they come in, you're ready to start. You do the general cleaning and the general irrigation. You come back to start with your first quadrant, and you get a slide, and they're filled with white blood cells. You didn't make the situation worse. They had none because the body was punting. They now have a lot of white blood cells because the body decided not to punt, to run for a first down. They're back in the game. The white blood cells are back in. If you're following good nutritional protocols, you're really going to see them. And they're going to be healthy-looking white blood cells. So that's important. And then they will decrease with time because they're no longer needed. You're winning the battle. They'll go on to other things. Example of a white blood cell. Leukocytes, WBC, whatever. Again, not a good picture. I think we might see that better on our slide. Red blood cells we don't particularly want to see. They're just empty holes, not quite air holes, but they're just empty holes on the slide. But they're there because of bleeding. They may appear clear, they may be dark. Bioconcave discs, that's a little hard to tell on the slide. If they're only significant in TNC, but again, it's a microscopic equivalent of the bleeding on probing. Visible blood does not obscure a diagnostic value. So if you put that down and you see the red in there, don't worry about it. It's fine. You're going to still see the activity. And these are just samples of red blood cells. Okay, the end. Now, let's go on to a microscopic slide. And we switched that on the input, right, Bill? Okay, this is one of the slides. I'm going to ask Bill's help. Now, I'm also going to ask Bill to stay up here and jump in anytime he wants on what we're looking at here. Now, you can see these are spirochetes, squiggly, sort of corkscrew-shaped. They don't move around a lot. I'd love to see a cigar rod run through here. That's not anything to worry about. But again, it's activity. This sample is 5 hours old. And it's still moderately active there. So you know that anaerobes, being out of their environment, a friendly environment, being in a hostile environment, anaerobes should be dead, but they're healthy. I had a slide in an office I visited to, again, teach a course, an office in Maryland, a one-day course that Kathy and I went and did. Kathy's my wife. And they had someone who had just come off 1 month, 30 days actually, of doxycycline and some other antibiotic that a dentist had put him on. And the dentist having us there for the course. And it was this busy. Well, let me tell you, folks, you're losing that battle badly. You're definitely getting into some antibiotic resistance, but it's not working. What does work is to go in there and take either, I used 3 things for in-office irrigation. I would use most often Therasol, which is at Oratec, and it worked in my hands beautifully. It would kill almost everything. If I thought it might be virally induced, which you can't see on a microscope, and sometimes you'll see, you know there's real bad periodontal disease. You're looking at the mouth, it's bleeding, everything else, and the slide doesn't show anything. It can be a couple things, but one of the things is a virally induced periodontal infection. And I remember when Jorgen Slotz first said that. I shouldn't even tell these stories on these guys, but that's okay. I do that. Kathy's not here to say, why do you do that? But Walter Loesch said to me, I think that's sort of garbage. And I said, I've got patients he's talking about. But with them, I used iodine, povidone iodine. It's 10% povidone iodine diluted 50-50 with distilled water. That's the second thing I used in the office. Well, that's the two things I used in office. I treated a lot of multiple chemical sensitivity. I might use grapefruit seed extract, but I prefer to use Therasol or iodine. And then at home, I'd have them using the periodontal patients, either Dental Herb Company's tooth and gum concentrate, tonic, sorry, thank you. Have them using the tonic. I'd have them use sometimes Therasol. Therasol is a little more expensive for home use, but effective. I myself use plain water. Spirochetes, you can see them all over. This is just really heavy with spirochetes. But let me emphasize again, this is motion. It's activity. There's no real, there's red blood cells. Under here? Okay, I'm sorry. Bill's pointing out to me. That's right. Okay, I'm sorry. This is a white blood cell, the nucleus in here. Again, hard to see. It doesn't transfer well to videos. What I'd like to do, that's a white blood cell up there. See the cytoplasmic granules? They're moving around in here. That's the difference. You go back to your zoology. Are there any brand new members of the IAOMT? Okay, one here. All right. When I found out that when I was in dental school, I used to kid Boyd Haley and say that I wanted him to write me an email immediately when he found one use for organic chemistry in the world. I never thought there was. And then when I got really into holistic dentistry, there's white blood cell. Really obvious, white blood cell. But when I got really into doing nutrition and treating chronic illness, and periodontal disease is a chronic illness that can become acute in different organs, but I had to go back and start studying things like anatomy, physiology, chemistry, and that sort of thing. Microbiology is a great one. To give you a quick shot also, the University of Maryland School of Dentistry, the Department of Microbiology, gave a course on microscopic diagnosis of periodontal disease. It was wonderful. There were 7 people there, myself, 4 staff members, and 2 other dentists. And it was a great course, and the Department of Perio squashed it. This is dark field microscopy. Now, dark field can be used for a lot of things. It's great for identifying spirochetes, but it's also real good for what's called red blood cell diagnosis in nutritional needs. And if anyone figures out how to do that, give me a call. I use other testing. But that's basically what you do with a microscope. And we're pretty well out of time here. But I will be around at the end of the day at the meeting at the end of the day when we all answer questions, to answer any questions. But that's the nitty-gritty of doing it. Just remember, get down to the bottom of the pocket, pull out a good sample. Again, great examples of white blood cells, spirochetes. There. These rods that are moving so fast can be a problem, but they're not cigar rods yet. That's a different spirochete. See the different shape from these over here that are squiggly? That's also a spirochete. So what you want to look for, don't get all intimidated by a case. Okay, thank you, Nestor. Don't get intimidated by the fact you can't name the bugs. It's not important. If the patient should say to you, and sometimes, being in the city with Johns Hopkins, I had a lot of patients who came in who were really knowledgeable and would say, well, I'd like to identify those bugs. And I'd say, well, sit down and we'll do a culture, because that's the only way I can do it. Some of those guys actually would look at slides and identify them. Too much. But you don't have to do that. This is so simple. It's not difficult. It's really simple. Motion is what you're looking for. Get down deeply in the pocket with a real thin little curette. You can even use, there's actually a purpose of those little indentations on a probe, a perio probe. No one ever knew what they were for, but you can put them down. They will pull out the bugs. But I prefer a spoon curette. Bring them out and put it on. Epithelial cells, all kinds of spirochetes again. Just debris, which everybody has in their mouth. Long gliding rods, you'll find those allowed just with gingivitis. But eventually spirochetes can get on the side of those, and I think they populate on. These are starting to get organized. See them joining together? That's an advancing stage. Any organization where they're joining together in any way, or they're gathering around a white blood cell. So you can't really say, well, if anyone's interested, I can give you my email to write down. Email me and I'll send you what are the, you know, the periodontal classifications, 1, 2, 3, and 4, 5, how they arrive at those. There's also risk factors for microscope diagnosis that I didn't bring with me, and I frankly just thought of it today. But look at this. Look at the organization. But those, if you want to get those, just email me. My email is TEB, Thomas Elmer Baldwin, TEB, KEB, at MD for Maryland, .metrocast, metrocast.net. And I'll send you those factors. And that just helps you to know how difficult it's going to be. Dan Waddle worked out a thing years ago where he'd take the periodontal case times the risk factor divided by 2 was the number of appointments. And as you find out over the years, that actually works. But you're going to be able to do that without going through all those machinations. Heavy spirochetes. This is an involved patient. This, I think it's a dead amoeba. There's too many vacuoles. That is an amoeba. And what happens, there's no cytoplasmic granules. That's why I'm saying that. Okay, it could be they've lost that. It's either, I think that might be an amoeba. But when you see amoebas and you see trichomonads, you've got advanced case. Yeah, a number of years ago, I was the chairman of the committee that wrote we call them protocols, now they're guidelines for, scientific guidelines for biocompatible periodontal therapy. I think Oksana Saviak is now the chairperson of that. And it was with a lot of help. But Trevor Lyons used to say that amoeba were the worst things you could find in the mouth. I actually believe they're a sign of real bad disease. That's why they're the worst only. That's my personal opinion. But this kind of case, if that is an amoeba, and we would be able to tell that, because if it is, and it's an early sample just taken from the mouth, you'd see a little pod form. And that's how it moves. It sends out a pod, and the rest of the body moves to it. It gets long and thin, and then goes all up like this again. Sends out a pod and moves on. It's sort of cool to look at if it's not your mouth. But this kind of thing impresses patients. It gets them to understand. But it should also get you to understand one of my pet peeves in life. You cannot remove this with string. Can't be done. If it's in a 7mm pocket, you can't get it with a brush. You must use oral irrigation to get rid of it. In the office, I used cannulas. I used a couple. ProDentec makes a real nice multiple thing for irrigation, and Ortec has the Viajet. You still have the heated Viajets. Patients love them because it heats it up as it's going into the sulcus. I can take a couple questions. Yes?
Are we allowed to ask questions?
Go ahead. Doesn't matter.
There are times when I see moderate to high levels of bacteria, but there was minimal bleeding when the cleaning was done and minimal probing.
Okay. He said at times when he sees a lot of bacteria on the slide, but there was minimal bleeding, minimal probings, things look pretty healthy, color of the tissue and everything. Okay, what that is a highly resistant person. It's an ideal case. You'll see that a lot in young people. That's someone who's not yet sick. You heard Dr. Jaffe talk about it this morning, and he talked about one of the great books to ever get in the world. Every scientist should have it on their desk, and that's Biochemical Individuality by Roger Williams, not the piano player. Anybody that laughs is over 50 years old. And that biochemical individuality talks about that. The infection is there. It's getting ready to start, but the body is killing it. So it's not able to take off. The body goes in and handles the battle. The problem comes when, 1, your immune system is down, 2, you're getting old, 3, they've had long enough to act, etc. And that's when the disease breaks out. But it's ideal to find this situation in someone who has no bleeding, no probings, and the gums look good. Because then you turn it around like that. Once you've diminished those bacteria, spirochetes, everything else, the white blood cells will clean it up. Bill, do you want to throw anything in here? Okay, yeah, if you go by the booth, Ortec booth, Bill has it, and it's much sharper when you look at it on there than it is on the video screen. Yes, sir?
What about delivering the antimicrobial solution through a Cavitron? Any problem with that?
The only problem, no, I don't have any problem with delivering through a Cavitron. The problem is that the Cavitron tips are usually so thick that you can't get down deep in the pocket, and the spray isn't really strong enough. If you use the cannula to irrigate, the cannula is so thin compared to the tip of a Cavitron, let's use the trade name, that the tip will go down to the bottom of that pocket. Now, it's also been shown when you've seen my lectures before that just regular use of a regular tip with a water pick will put your substances down to the bottom of the pocket about 85% of a pocket 7 millimeters deep. That's incredible. Oksana.
One of the issues that I have with touching gums that look like that under a microscope is when you do push it into the sulcus into the bloodstream and getting rid of it nutritionally or with an antibiotic you have to cleans up that so that you don't push it into the bloodstream, and then it doesn't matter whether you put anything in the Cavitron or
Yeah. Good point. You can use the antibiotic ahead of time. Now, if you're using antibiotics, I will caution you that I think it's a good idea to do a culture. Because if you're using antibiotics, you better know what you're using if the bugs are susceptible to that antibiotic. They also have biochemical individuality. The second thing is if you use an antibiotic too often, the pockets tighten up and it's tough getting to the bottom of the pocket. But you don't want to be forcing things into the bloodstream. The question before about the person that had no other signs of periodontal disease, they're probably healthy enough that it's going to clean up itself anyway. The other thing I do is I don't just run this stuff going into the pocket. I will go down to the base, and I used a lot of povidone iodine, 10% diluted 50-50 with distilled water, and I'm killing them as it's coming out. I always use nutritional supplements with and again, if we go on, if Rich has us for this breakout, which it sounds like he's going to, I will go into nutritional treatment of that. And like I say, I go to offices and do it if anybody's interested in that. But okay, I will be around to answer questions at the end of the day. Bill, did you want to add anything at all? I want to thank Bill Landers of Ortec for all the help he's given us in doing this and all the help he's given the Academy over the years. Thank you very much.